welcome to the Home of Medicine podcast with me, Amy.Burbridge.
And me, Ben Lovell. Nice to see you again, Amy.
Nice to see you, Ben. So you've got a case for me?
I do. It's an oldie
Okay.
but goodie from the history books. This happened to me when I was an ST3 in acute medicine, a first year as a registrar, all the way back in 2000 and mumble.
2000,
And
I say it was 2009?
how dare you? It was 2010.
Really sorry. Okay.
But you don't do an ST3 anymore in the UK in acute medicine.
No.
It starts ST4. But I was ST3, brand new registrar, just sort of still working my way into the role. And I came onto a night shift, and it was 10 p.m. So not long after we handed over, and I was in my night shift, very busy in A&E. And I was phoned by the FY2 SHO doctor who was covering wards and says, please, can you come urgently to the gastro ward? I need help. The nurse asked me to come and review a patient. This patient is being treated for decompensated chronic liver disease, which is due to alcohol. I've been asked to see him because he's having melena. His systolic is 84. Please come and help me. So, what are you saying on the phone, and what are you thinking about in the lift on the way up to the ward?
So, number one, I never get the lift anywhere in a hospital, Ben. I always walk up the
Okay.
stairs. I have an irrational fear of the lift breaking down and me being trapped in the lift. So,
I thought it was you say because you wanted more thinking time, so you take the stairs. 15th floor. I'll be there at midnight.
We're 2 hours later. So you've got a patient who's on the gastro ward, decompensated liver disease,
Mm.
presenting with melena,
Mm-hmm.
and the SHO's calling you and asking for some advice.
Mm-hmm.
Okay, so in my head, I'm running through the A to E. So I'm going to be asking the SHO, is the patient sitting, talking, breathing? What's the GCS? You say that the blood pressure's 84. Do they have any cannulas in situ? Is there any fluid running? Is there any blood running? Have you taken any blood? Have you done a group and save? Have you done a rectal examination? Are they actually passing melena? Have you seen it? Are they vomiting? Is there any hematemesis? Is
Mm.
there vomiting blood? Is this esophageal varices that we're dealing with? Does the patient look ill? Do they look well? That typical end of the bed test. I'm going to be asking them probably whilst I'm on the way climbing up those 15 flights of stairs, if there isn't cannulas in, to make sure they've got IV access, to make sure there's fluid going through, cross-match blood, look at the drug chart. So are they on any blood thinners that could be contributing to this? Are they on any other medication that could be contributing to this? Is there a background infection that we need to give them some antibiotics for? I guess this is all in my head rather than to CSHO now. I also would probably say to them, you probably need get some help as well from the ward. So maybe one of the nurses on the ward to come and give you some support. Maybe get the F1 to come and give you some support. With experience managing individuals with decompensated liver disease with melena and a low systolic, they can become very ill, very quickly. It's really important to get some support. So whilst I'm on the stairs, what am I thinking of? I'm thinking of, okay, do they need clotting factors? Do they need reversal agents if they're on warfarin or if they're on a DOAC?
DOAX didn't exist in 2010, so that's a no.
Oh God, they didn't, did they?
No.
That just shows, gosh, they didn't. It was good old warfarin, wasn't it? Or okay, so they may have needed some warfarin reversal, then some vitamin K. Get a little bit more past medical history, thinking maybe, will I need to speak to the gastro consultant on call if there's hematemesis? Do I need an urgent ODD? Catheter? It's not very structured, that wasn't then. I'm fully aware that that was a bit garbled.
Well, sometimes it isn't. I mean, I'm interested
Yeah.
in internal monologues when you're making your way from A to B,
Mm.
and there's a crisis waiting for you at B. And we talk a lot about cognitive aids, and when your brain goes into scrambled egg, all you can do is just go, okay, what do I know? A to E, like you said, is the airway patent? Tick. B, are their sats okay? Tick. C, and work your way through it like that, because as you say, you can go in five directions at the same time. Because it's a very complex condition. If I can try a little bit of acting now and just tell you what the FY1 said to me on the phone, as far as best I can remember, something along the lines of, I asked a few questions. I said, okay, do they have IV access? And what were they like earlier? And how do they look today? And what the rest of their obs? I don't know. he looks terrible. He is massively melena. I've never seen so much. His blood pressure is just gone right down. It's 80, it's 84, it's 81. It was 120 earlier. Oh God, I think, can you come? Can you come now? That was the sort of handover.
And I understand that from an F1 resident doctor. I genuinely think one of the scariest things, in fact, probably the scariest thing I've ever seen as a doctor at any stage of my career, is massive melema and hematemesis. And the first time it happens, it's really quite scary,
Mm,
particularly with the varicose bleed as well, because it's
mm,
everywhere. And there's a
mm,
specific smell. I don't know whether
mm,
you agree, like that melinery smell, that blood smell is
mm,
it's quite distressing actually. So I get that panic. I understand it. And actually, even
mm.
now, I probably panic a little bit as well.
So what is our role then as the registrar receiving that phone call? What's our best leadership choice there, the management
Oh,
choice of that FY1? And what kind of stuff do you say on the phone other
on the
than
phone.
saying, okay, I will come? But is you give them a talk or do you give them a job or what do you do?
So I give them something to focus on. I give them a job. So I would say something like, I understand this is a really scary situation. What I really need you to do is to go sit with the patient and get a cannula in, get
Mhm.
IV access, take some bloods, and send off an urgent cross match.
Mm,
Get another member of staff to come and sit with you and
yeah.
keep talking to the patient. I think
Mhm.
that's really important because we're scared in this situation, and the patient's even more scared in that situation. So I think it's really important. Keep talking to the patient. I'm going to give you a job to do, and I'll be there as soon as I can.
I'm very similar. I think when people are panicking, which is a really understandable response when you're experiencing a certain medical crisis for the first time,
Mm.
focusing on simple tasks is actually easy to do. And saying something like, okay, I'm on my way. I will be there in a few minutes. Whilst I'm coming, please can you get as many cannulas into the patient as you can, green or bigger? Just
Mhm.
get that done and get bloods off. And please make sure that we get these certain bloods. And it gives them something to focus on. And I
Yeah.
do sometimes watch phone calls happening when people ring for help, up a hierarchy, up the chain, and people sort of give them advice over the phone and maybe, well, can you try this? And then call me back if that doesn't work. And
Mm.
sometimes I'm listening, I think you need to go.
Yeah.
I think you need to just go there because I don't think they're going to manage this. Even with the fantastic phone advice you're giving, which is very, very good, I think you're going to have to go there and just check it out for
Mm.
yourself.
Mhm.
And I think that is an interesting part of the medical registrar role. We talk a lot about the med reg role, and it's a role I did for 7 years. I really enjoyed it. There were certain days where I hated it, but my net opinion of it was a role I enjoyed because it was a role of enormous responsibility, which I think comes through with the case I'm about to talk to you about. But that was a task I gave. And then the way going up in the list, just like you, I'm thinking, okay, liver disease and bleeding. Either it's going to be varicose or it's going to be non-varicose. I hope it's non-varicose because varicose bleeds are a nightmare. Although I was still pretty green, an ST3 in acute medicine. I'd only been practicing medicine for 4 years at that point. I hadn't really seen a big varicose bleed before. I knew theoretically what was going on there. I knew what a varix was. I knew that if it bursts and bled, then they can exsanguinate pretty quickly. Hadn't seen it in action. But so I'm thinking, okay, Ben, you're up. Right, here we go. What are we going to do when we get there? We are going to be a really good med reg. We are going to be calm and in control of the situation. We're going to do an A to E assessment. We're going to get loads of volume into that patient, and then we're gonna speak to the endoscopist on call, and we're going to organize a scope. Okay, this is really straightforward. Here we go. And I got to the ward, and actually the patient looked okay. There was a little gang of nurses around the bedside with the FY2, and they were all helping together. And the FY2 was diligently putting in large bore cannulas. And I said to the patient, who was a very nice looking man in his 60s, I said, how are you feeling? And he opened his mouth, but instead of speaking to me, he projectiled liters of fresh red blood. And that went up my trousers, it went up the bed, it went up the walls. And in about 2 minutes, he had filled two very big sick bowls with just fresh red blood with big, thick clots in it. So this wasn't just someone with melena. This was someone who was having a very brisk upper GI hemorrhage. And in fact, we were going into emergency mode. I quite like emergency mode. I chose acute medicine, but it is blooming scary when you find yourself thrust into it, especially on a night shift when your cortisol levels are low and you really wanted a straightforward shift. You didn't want, to come in and be dealing with too much burn. It's because you're tired and your biorhythm is all out of whack and your eating is all out of whack. But that was the hand I've been dealt with that night. So I've got this man throwing blood at me. I'm doing an A to E, airway unsafe.
Very.
He's aspirating gallons of blood. It
Yeah.
was crazy. He was actually vomiting up more blood than the nurses could take away. All they could do was keep replacing his full bowls with empty bowls. And very soon there was a collection of full bowls of bright red blood sitting all on the floor around the bed. We were trying not to step in them. His SATs were 90%. They went up on 15 liters, but couldn't keep the 15 liters on because he was vomiting blood at very, very high pressure. So all we could manage was put some nasal specs on and give him 2 to 4 liters. His heart rate was only 115, but his BP was 80/40, and he was clammy. He became very cold and shut down. For D, he was alert and he was frightened. And I was trying to reassure him in between these very spectacular bouts of vomiting. And for E, for exposure, what can I say? There was melena in the bed. His abdomen was soft for what it was worth, and there was nothing really else of note. So that was what I was dealing with. So what would you do in that situation?
Now, I've been in this situation twice. And as I said before, I think it's probably the scariest medical emergency for me. Similar to you, I remember a time when I also got covered in blood and ended up throwing my clothes in the bin. It's just another level of scariness, and it's so awful for the patients, relatives, and everyone really. When you're in really difficult situations, emergency situations, which, as you say, is part of the reason we chose acute medicine because we like that adrenaline. I do sometimes, I think, as I get older, the more I get in my career, I think I panic a little bit more now, which is crazy than I used to. I think I've lost a bit of my confidence, but I always go back to A to E, and I think that's really important. You know, it's really difficult to get a patent airway when somebody's vomiting. So lie them on their side is often something that we do with somebody who's exsanguinating such large amounts of hematemesis, because what you don't want them to do is to aspirate it and to go on their lungs. Sometimes a nasopharyngeal airway can be helpful if, it's you're able to do that. That can be beneficial. The breathing, again, with oxygen, you can't put a face mask on because the amount of blood. See, you've got your cannulas in, fluids, cross-match, blood. When you're losing that much blood, you need to call massive hemorrhage protocol. And different hospitals may have different numbers. Normally 2222, you call and you'll say massive hemorrhage protocol on ward 22 or wherever it is. And this then activates a cascade where the hematology laboratory will know that there's a problem. You'll need some O-neg blood, probably some fresh and plasma, maybe some cryoprecipitate, some PCC potentially. And they'll also, one of the most helpful things, a porter comes and is able to deliver and help with that. Catheter in antiemetics can be really helpful because they're vomiting, although it's not usually a vomit as such. That can be helpful. Antibiotics, because sometimes infection can have triggered it off. When somebody's losing this much blood, I'm probably going to need some intensive care support maybe, and a gastroenterology consultant on call to think about banding the varices after stabilization, and also potentially, I've never seen this done, a Sengstatin Blakemore tube insertion.
Oh, what's a senstatin plate?
Do they even use it anymore? So I know they do. So basically it's a tube that goes down into the esophagus, and it's like a balloon, and the balloon expands and compresses the varices that are bleeding, and it can be used in an emergency situation, and it stops the varices from bleeding when there's so much blood around and you can't band them because you can't actually get that sort of the band around the varices. That can be helpful, but it has to be done by a specialist. Certainly I wouldn't feel comfortable doing it.
How interesting. How interesting.
Did you put a Sengstatin Blakemore tube?
Well, hey, let me. Basically, I did what you did. 2222 major hemorrhage protocol. We need to replace volume, and it's got to be volume with red blood cells in it. All we can replace there on the ward is normal saline Hartmann's or whatever. And I knew that it wouldn't be long before his entire circulating volume was replaced by Hartmann's solution. So we needed to get blood products there. So I did that 2222. And the porter came with the bag, which had 4 or 6 units of blood cells in, as you said. I think it has a couple of pool of platelets and some other bits and bobs. And I just said to the F2, oh, and of course, it summons a few other people. It summons the anaesthetist. And it put out, the hospital I was working with, it basically put out the crash course. So the crash team turned up. So I knew we can now then assign jobs. I need you. I don't say you, I say names. I said about who it was. I need you to keep getting IV out. How much we got? 2 cannulas, not enough. I need 4. Can we make sure that every single cannula always has something running into it? Blood, please. Get the blood in now. We're probably going to need some more blood. So let's ring the lab. Can the porter pick up some more blood? The catheter, yeah, I didn't get around to that. It was all hands on deck, unfortunately. I said we need to give some more bits and bobs. Back in those days, we gave IV tranexamic acid. We stopped giving that a few years ago. Tranexamic acid is an antifibrinolytic drug, and we used to give it in GI hemorrhage because we thought it would prevent blood loss. It would promote clotting. And then there was a big trial, I want to say 8-ish years ago, called the HALT-IT trial, which showed it absolutely did nothing. So we stopped giving it. But in those days, we gave tranexamic acid. Okay, let's give tranexamic acid, try and switch off the bleeding. Terlipressin. Terlipressin is a vasopressin analog, and we give it, the only time I ever give it is for variceal hemorrhage. You can give it as a vasopressor in ITU and other circumstances, and you can also give it to prevent people from developing hepatorenal syndrome. But I only ever gave it that. So I knew 2 milligrams of terlipressin IV, get that in now. It causes splanchnic vasoconstriction, so it reduces blood flow to the area that's actually losing blood. So I knew the tranexamic acid, I knew the major transfusion, I knew the terlipressin. I did not know an up-to-date INR, but I said, you know what, let's give IV vitamin K because maybe he's coagulopathic and because he's got chronic liver disease. So 10 milligrams of IV vitamin K, let's get that in as well. Antibiotics you mentioned. Yeah, I gave IV cefuroxime because I knew looking at him, there was no way he has not aspirated significant amounts of gastric blood there. He has definitely done that, and he's definitely going to get an aspiration pneumonia. And also, when you have a GI hemorrhage in the context of chronic liver disease, it triggers translocation of gut bacteria, and you can develop bloodstream infections, bacteremias. So broad spec antibiotics. Those were the easy stuff. That's me saying to nurses, can you fetch me 1 of those, 2 of those, 3 of those, 10 of those, and then just shove them into any cannula. And in the days where you just had paper drug charts at the end of the bed, you could scribble down a prescription and they would give it. Whereas now you've got to find a computer, find one that works, log on, prescribe it online. Anyway, moan. So all of that was my attempt to try and turn the taps off. But when someone's having a variceal hemorrhage, it's very difficult to turn the taps off without endoscopy. As you mentioned, someone's got to go in and physically do it by banding the varices. So what I was doing was sort of trying to keep filling up the bathtub while the plug hole was draining and try and maintain some kind of homeostasis. But you're not going to get anywhere until you get an endoscopist on. So I rang the on-call bleeding red amidst the drama. This was going on a while now. Everyone was caked in blood. And they said, I can come in. I'm at home. He sounds way too unstable for us to scope in this endoscopy unit. I think he's going to have to be intubated and scoped in theatres. That sounds like the safest way of doing things. Can you arrange that? And if he's still hemorrhaging blood, you're going to have to pop in a Senstack and Blakemore tube. I said, but I've never done one before. They said, well, it's easy, and it is on the GIM curriculum, as it was in those days. MedReg, it's a skill that a MedReg should have alongside a chest.
Absolutely, yeah.
He said it's very easy. You get them to tube them first, so that way the airways, the trachea is blocked off, and then there's only one hole left. Just pop it in, push it down behind the endotracheal tube. It'll go right down to the stomach, and when it's in, you inflate the balloon. Then just pull it out and hang something heavy off the end so it acts as a stopper at the gastroesophageal junction. Hang a bag of fluid off it and dangle that off the side of the bed, and that might tamponade the bleeding. It might compress the varices. He says he might die without it, so you're going to have to crack on and do it. And I spoke to the anaesthetist. They said, yeah, we'll tube him. We'll tube him. We can take him to ITU. But obviously, we need to do the endoscopy. The endoscopist's on his way. The outreach nurse found a Senstack and tube. She said, yeah, we keep them in the fridge because it makes them a bit more firm. And I said, okay, so now we need to put a Senstack and tube in. And we all sort of stood there at the bedside, and I realized everyone was looking at me. The MedReg. The MedReg can do anything. The MedReg has ultimate responsibility out of hours for every medical patient in the hospital. You are the top of the chain of command. If anyone's going to do it, sir, it shall be you. I got the instructions out, the packet,
There was no YouTube videos then.
no YouTube videos. So, and I had done one a long time ago in a sim lab, which seemed
Ah,
very,
yes. Yeah.
and I had a real moment of like of quandary saying, what is the safe and appropriate thing to do here? Have a go because he might die without it.
Mm.
Do it. I don't know how, but maybe risk harming him somehow more by making a mess of it, by getting it wrong,
Mm.
and then causing patient injury, and then having to answer some very difficult questions saying, well, what made you, Dr. Level, feel able to do this procedure, which you've never even done supervised before, and you had been inadequately trained for? Is that a defensible position to be in as a trainee? This
Mm.
was the conversation in my head. So I'm
Mm.
standing there. The patient is now unconscious and intubated, and I'm holding the tube. What are you going to do, Amy?
I'm just scribbling down notes here. I'm gonna give it a go
Why?
because if we don't do that Sengstatin Blakemore tube, he's got a very high chance of dying. If an intervention I can do that, although I may not have done before in a person, but I've done in a lab, sim lab, which is often how training for procedures is done now, although it wasn't then. If that can potentially increase his chance of survival from maybe 10% to 20%, then I'm going to give it a go.
I did.
Yeah.
I did. I don't think the average, I don't know. I don't think many people these days would.
I'm
I
not
think,
sure whether I would now.
yeah, okay, yeah. And I think that's a cultural
Mm,
thing,
mm.
not as a generational thing. Like, oh,
No.
doctors these days. I'm talking about the culture with the safety culture we live in
Yeah,
now,
yeah, yeah.
and how the see one, do one, teach one training model, which I was brought up on, is no longer considered acceptable from a patient safety
Yeah.
point of view. I think doctors would really worry not only about harming patients, but worry about what they would leave themselves liable to if it were to go awry. Would they
Yeah.
be protected and supported by their supervisors and by their trusts? Will I be hung out to dry? Could this
Mm.
be a GMC issue? This is the sort of thing people worry about.
Mm.
But I had the same decision process that you were making. I think we've talked about this before, but in human factors, there's a process called FORDEC, FORDEC, which is when you are stuck clinically and you don't know whether to proceed or not. And it's an acronym, and it's FORDEC. F stands for facts, O stands for options, R is risks, D is decision, E is execute, C is check. So FORDEC, facts. What are the facts? This man is hemorrhaging to death in front of me, and I don't think an endoscopist is going to get here in time to save him. Options. One, we keep transfusing blood products and we pray, we hope. Option two, I have a go putting this little tube in and inflating it and maybe switching off the bleeding. I've done it once on a mannequin. I can barely remember. I've never even seen it done in real life, let alone done it myself. And there is no one to supervise, teach me while we're here. Risks. Risks of not doing it, he dies. Risks of doing it, he dies anyway, but he might be saved. Decision, I made the decision to do it and I executed and then I checked. Actually was really easy. There's one end, which is clearly the bit that goes into the page. It looks like a very thick NG tube. And then at the end, it's got little ports on. On one port, you stick a big 50 ml syringe on and you inflate. And the other port you can aspirate out. So you can aspirate out blood from the stomach, from the other end of the tube. And you just push it in. And it was just like he said on the phone. He was intubated, so there was no danger of going down the wrong hole. You just push it in and it slides beautifully down the esophagus, all the way up to the mark. Then I inflated it with through the port with 50 ml syringe. And then I pulled on it, gave it a bit of traction. So I'm just imagining my head, it's a little stopper, and I'm squeezing the gastroesophageal junction with it. And I hung it off the side of the bed, tied to a 1 litre bag of fluid, which I know is 1 kilogram. And I left it there and it was done. Everybody was watching me, maybe
Mm.
10 people, um, thinking about the cognitive bandwidth of being watched doing something you are incredibly nervous about doing and how that might make you more prone to errors. But, I had to crack on and do it, I felt.
Mhm.
And the strangest thing was, once I did it and I put that bit of attention on it, his blood pressure suddenly went up to 100. It was like the taps had been switched off. And because all the varices, the blood supply that runs to the esophagus, does run via the gastroesophageal junction. There is a third port you can inflate, and that inflates the sausage-like balloon which runs inside the esophagus. I didn't inflate that because I remembered that you only inflate that in desperation. The risk of inflating it is that it can rip or tear the esophagus and cause Boerhaave syndrome. So I didn't. I just inflated the gastric one and pulled a bit. And it seemed to buy us time. It seemed to work. And the patient went to ITU and they scoped in ITU and they banded the varices, and the patient survived to discharge. And this was one of those shifts. And I don't think I ever had these shifts except when I was in the med reg role, was when you finish the shift and you are walking 10 feet in the air. You are absolutely on cloud nine. You not talk about making a difference. You saved a life. And it's nice. You get a lot of admiration from people, which always, is nice. And people say, oh, wow, that was the most amazing thing I've ever saw. That I've never seen that done before. People say to you the next day, hey, I heard that you put in a blooming Senstack and Blake water tube overnight last night. That's crazy. Have you done that before? What happened? How? That feels nice. But it's one of those things I was absolutely buzzing. And it's one of those examples in professional identity formation where you get these moments where it really cements the feeling of being a doctor rather than still being in training. I'm in training in a training program. It's like, yeah, but I felt like I was a doctor in that moment. Could have gone wrong. How would I have felt if I did all of that and he died anyway? Probably absolutely awful. But I feel like as long as my sense I can do hadn't contributed to his death, I would have felt like at least I tried. I tried everything. And the patient didn't die because of my nervousness to give something a go. I also think that if he had, unfortunately, if he had died after I'd done that, maybe not then, maybe not in 2010, but I think now I would have been invited to some meetings and people said, Ben, do you think that was an appropriate thing to do? We're not quite sure. We wonder if you're a bit overconfident, or I don't know. This is all my imagination, but if we can visualize that happening quite easily. But the case for me was a real difference between knowing about something and being able to do something. Have you ever had a moment like that?
I'm just scribbling things down in my book, which I have to still write things down. I still haven't quite made it onto computers for everything. I'm just thinking, I mean, I have had a couple of moments like that, and I've had them where they've been successful, and I've had them where they haven't been successful and really tragic. Not necessarily something that I've done wrong, but something that was going to be tragic anyway, and whatever I did was never going to help. But it felt like even though I tried to do the best I could, I didn't feel like I made a difference, and that they're really, really difficult cases. Um, there was a case where I remember doing a femoral line insertion in A&E Resus. It was a little district general hospital, and I was an ST1 or 2. So I've been a doctor for about 2, 3 years maybe. And back then, femoral line insertion was done blind.
Yeah, I remember that. Yeah.
Ultrasound didn't exist. Well, it did, but nobody did it. It was very much anesthetic, maybe, even if that, not done much. And I remember putting a femoral line in blind and people watching it going, oh my God, she's amazing. She's put this femoral line in. I'm like, oh, to be fair, I think it was probably more luck than skill. And we were able to really help the patient because we were able to get more fluids in and blood, and that was a GI bleed as well. There probably has. I think the problem with my professional identity and how my professional identity has been formed is I think in the last few years, I can only remember bad things that I've done. And I'm not sure what that's a symptom of. Um, but I'm really struggling to think of something where I've made a positive impact in a patient. And isn't that sad? I must have done something. And I think that's maybe I'm at the time in my career now where I don't know. I'm exhausted. I've seen so many patients. I've done so much, and it all feels a little bit overwhelming at the moment. And sadly, I can't remember. My professional identity at the moment feels like it's been formed by negative rather than positive outcomes. But that's something for me to probably go back and reflect on and think about for the next podcast we do.
But you've talked on previous episodes before very honestly about burnout. We
Hmm.
did a case actually, which was a bit of a trick case because it was a case of a woman who had persistent
Oh,
symptoms. Um,
we've never
the one,
released that one.
that's okay. I'm not gonna say any more because I don't want to get spoilers.
Yeah.
But there, you said before about the symptoms of burnout, and you talked about your experiences before,
Mm.
and one of them is only remembering the bad stuff and not really feeling like you'd make a difference if you were there or not. Very easily dismissing things that you do well, like you just did, like, oh, it probably was luck rather than skill that got that femoral line in, it ties in with imposter syndrome. Wait till they find out that I don't know what I'm doing, all that sort of thing. And I think it's important that we talk about it because I think it's important that we recognize and discuss the symptoms because people out there listening will have similar symptoms but not know what's going on. And I've had trainees before saying things like, I think I'm having a nervous breakdown. Oh my gosh, I don't know what's going on with me. I don't think I've done anything right. I'm
Mm.
making mistake after mistake. I don't think we're doing any good here. I don't think I'm doing any good here.
Mm.
And I tried to gently point out, well, what about that case yesterday where you did this? What about that patient you saw this morning where you made that happen? And it's remarkable how easily people will dismiss that. In a way, they wouldn't dismiss other people's achievement, they will dismiss their own. I remember being told as a very, very junior resident doctor saying, someone said to me, you can't do down your own accomplishments because lots of other people will do down your own accomplishments in life. You have to champion your own and recognize them and put them in the memory banks. But sometimes it's easier said than done.
What? Sorry, we're just going to take a time out here. What I'm thinking is we finish this episode and then we can do 10 minutes on burnout.
We can do what?
We can finish this episode and
Yeah.
do 10-minute quick one on burnout.
Okay.
What do you
Do
think?
you want to reference it in this one and
Yeah,
say, but if we have a special bite size coming up
yeah.
soon after this one, which we
What
do
do you
talk about
think?
then. Yeah, let's do it.
I think it feels like this will just generally segue into that.
Yeah.
Yeah, okay.
Okay.
Yeah, and we are going to do a sort of a bite-sized episode on burnout very soon. So please listen to that when it comes out. Going back to your case, what do you want us to take away from this, Ben?
Well, it made me think a lot. We are both now very heavily involved in medical education, and I now think of it through an educator lens, as well as
Mm.
a sort of a clinical lens. And I think about how we teach rare but crucial skills, rare but critical skills. Senstack and Blakemore Tube has fallen off the curriculum for medical registrars now, and I suspect it's because we now have access to much more effective treatments for variceal bleeds, such as urgent tips poor systemic shunting, I mean, and also we've much more improved access to emergency endoscopy, which was historically a bit patchy. So the poor old Sensac and Blakemore tube has sort of gone into, I suspect, the museums now, although it probably does have a role in certain situations. But it made me think about autonomy and supervision and about how we prepare trainees for when supervision isn't always available, but critical skill or performance is demanded. How did I know? Simulation. I think so. It was a mental recall of a diagram, a dusty skill from a sim lab many, many years ago. But I think simulation is really critical for rare but life-saving procedures because repetition in a safe environment makes you much more ready in the middle of the night to crack on and do it for real. And I think that when people talk about simulation, they often talk about the what we call full immersion sim, where you're in a scenario, a bit of acting, and you're doing a bit of role playing. But the hands-on critical skill stuff, where you familiarize yourself with kit, with actual equipment, the sequence that things should be used in, actually probably saved the day in my particular scenario here, because that was the only reason I had a vague inkling of what a Senstack and tube was. And it made me also reflect that crisis is a very powerful teacher, but it's not the safest or the fairest way to learn. Yet it still is the crucible of learning for many doctors working in healthcare today. And we can mitigate that as best we can by making sure that people are prepared, for example, in a simulation lab before they meet these scenarios head on. But I don't think you can cover every eventuality. And there's something about being on the night shift where there is no supervision available that makes you feel more able to do something. I think during daylight hours, I wouldn't have done it. I would have said, no, this hospital is full of people much more experienced than me. This is really, really inappropriate. I will not do this. And that's the end of it. Whereas at night, even though I was only in ST3, because I was nominally in charge, I was in a leadership role, that leadership imbued me with a confidence, I suppose, or at least enough pluck to say, I'm going to give it a bash. And I think, therefore, responsibility is a learning tool. At my hospital, for example, we're one of the very few hospitals where our FY1s do night shifts. And people say, well, why do you put FY1s on nights? I'm like, because they're doctors. And the feedback is good. They say the first time I ever did X was on a night shift because I had to. I had the responsibility and I went to review this chest pain on the night shift. Then I spoke to the med reg. During the day, I would have immediately escalated that up to an SHO or reg, and they would have done it. And maybe I would have watched. But the responsibility gave me the superpower to do it. And therefore, I do think responsibility is a really, really interesting adjunct in medical education. And I think we rob resident doctors of responsibility at our peril.
I remember doing 7 nights in a row as an F1.
Me too.
They were vital to me in my own development, I think. I did some crazy things. And they were really tough. That 5th night was awful.
Yeah.
But the 4th and 5th night were dreadful. The 6th night was okay. The 7th night you were euphoric because it was the last.
Yeah.
But they were tough. But I'm not saying we should ever go back to 7 nights in a row. It's really But I think there is a role for nights for all levels of doctors, all resident doctors. And
the first central line I did was on a night shift.
Yeah.
Because I had to, no one else was going to do it.
The first thrombolysis I did.
Thrombolysis, yeah.
Yeah, that of an MI. Do you remember we used to thrombolyze MIs?
I do, yes. I remember thrombolizing STEMIs, yeah.
Yeah. We need like a reminiscence episode, don't we? In my day.
That'd be so boring.
Yeah.
They're talking up in our listening numbers for that one.
Yeah.
Good time, so what the hey. So I hope people enjoyed that little vignette. It's a bit different to what we normally do. We normally do a patient in the front door and then we try and work out the diagnosis. Here, the diagnosis literally slapped me around the face and went up my into my shoes. And I had to make some decisions. But FORDEC, as an acronym for decision making, when you can just put things very black and white for you and make you understand what the facts are here. And I think that grab every opportunity you can to practice things, especially procedures, in the light of day, so that you are not surprised, unawares. And if someone says to you in daylight hours, do you want to come and have a bash at this central line and I'll watch you? Don't let your nerves say, no, I don't feel ready. I don't feel ready. Do it. Because the next central line that presents itself to you, you might be forced to do it.
Definitely.
So hoover up all the experiences you can to watch, to have a go, to facilitate, to be an assistant, to be supervised, and don't let nerves or shyness or lack of confidence get in your way, because these are all really skills that all go in the bank and then they pay dividends later when it counts.
Absolutely. Thank you so much, Ben, as ever. Great case, some really interesting takeaway points for me as well, in particular FORDEC. In that really difficult situation, it's like the A to E approach. It's having that sort of that cognitive debiaser, that checklist, like the WHO checklist in theatres. This is like the checklist for those emergency situations. So thank you. Massive thank you to everybody for listening. Please rate, review, subscribe to our podcast, because that's how the show gets bigger. Thanks for listening. Goodbye.
Bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.